Hi, my name is Chandel Ulmer and I am a student physical therapist assistant at Jeff State, and today my presentation is going to be on Paget's disease of bone. So the first thing we're going to talk about is actually this picture. I just want you to take a look at it, and what is it? What do you think it is? You might think that it might be some genu varus of the knee because you kind of see the bowing out right there, and then this knee is normal. But this is actually what Paget's disease can cause. It can cause a deformity in the bone. Paget's disease is defined as an abnormally progressive bone disease where the osteoclasts build or break down the bone, and the osteoblasts try their best to build it up, but instead of laying down normal bone tissue, they lay down a thick fibrous tissue that can cause a lot of pain and deformities. Some of the common places that you can find Paget's disease are in the hip, the femur, and the tibia, as well as the skull, and we saw the picture with the tibia. Due to the bone being laid down in an unorganized fashion, the disease can have a lot of effects, including pain, as well as eventually leading to osteoarthritis, but it can also cause things such as impingement of nerves in the surrounding areas, as well as ischemia of the involved areas, and vasodilation that causes an increase in cardiac output. So diagnosing the disease. Many times it actually goes undiagnosed until someone goes in to find something such as osteoarthritis, and then they find the underlying cause to be Paget's disease. Symptoms start as a diffused ache and then leads to pain and potentially, if not caught early enough, deformity and arthritis. It can be found also through radiographs, alkaline phosphate level blood tests to test for the osteoclast activity, and bone biopsies. And if someone is found to have Paget's disease, many times their family members are recommended to come in every 2 to 3 years to be tested for the disease. So who can actually get this? Well, it's actually genetically linked. A third of the people with this gene, SQSTM1P62, end up having Paget's disease within their lifetime. So how do we manage this? Well, it eventually will affect people around the age of 50, but it can be seen in people as early as the age of 35. And prognosis is a lot better if it is found earlier in the person's lifetime, because it is more destructive as it goes on and can actually lead to different kinds of cancer. We can manage it through pharmaceuticals, through bone reabsorption inhibitors that stop the effects of the osteoclast and can even cause cell lysis and destruction. We can also use bisphosphonates. These are taken up by the osteoclast that also causes them to die off. A 6-month clinical trial actually yielded results that the bone turnover rate was drastically reduced with the use of these drugs. And so sometimes doctors will look at patients who have similar effects as Paget's disease and tell them to use these drugs because they know that they are effective. NSAIDs can also generally be used for pain and inflammation that happens in the area of the bone tear down and build up. Surgery can also be an option if there is compression of a nerve or occlusion or anything like that, just so that the person can function normally and not have lasting effects like that. And obviously, what we're here to do, therapy. So now we're going to look at the Nagy model as it goes for Paget's disease. So the impairments we might see is a decrease in the strength due to activity from pain and possibly guarding of the area. Functional limitations include sit to stand might be difficult, especially if it's anything affecting the lower extremity, which is the majority of what we see in Paget's disease. And the disability is trouble in general performing ADLs, such as walking to get the mail or standing for a long period of time to cook or do dishes. So how can we kind of go about working with these impairments? Well, obviously, we can make sure that our patient stays active. If they sit down and don't do anything, then that will just promote more inactivity and more pain when they do try to do an activity. We can work with strengthening and especially doing isometrics in the beginning, depending on how far the disease has progressed, and then work on PNFs like we have learned about in class, because this allows for non-weight bearing and a decreased chance of falls. Because of the nature of the disease, falls can create a lot of issues because the bone is at an unstable state. And we can also use e-stim for both pain or initiation of contraction depending on what the patient needs. So some precautions or contraindications that we see: there is obviously an increased risk of fracture because of how the bone is being broken down, and you also need to be aware of what drugs they are on and what side effects the drugs can have on the person. If they're going to be tired, then they might be at more increased risk of falling or having an issue while in therapy. You also need to just take exercises slow to ensure that they understand what they need to do, as well as to decrease the risk of falling. Patients also may have comorbidities because that they are inactive, such as obesity or diabetes, if they have a less active lifestyle. Some more important things to note: osteoarthritis is one of those things that inherently happens with this disease. It is progressive, so it may be very painful for the patient, especially if they choose to not take medications for this, which is the route that a lot of patients take, to take medication. And we are also just trying to help them in general regain strength and function to be able to perform ADLs. So in summary, Paget's disease of bone is an abnormally progressive disease where there is rapid bone breakdown and buildup, resulting in pain and abnormalities. It affects those who are 50 years or older with a possible onset as old as 35 disease. Prognosis is always best if it's found early, because then something can be done before a deformity is caused. And it can be treated through bone reabsorption inhibitors, biphosphonates, and NSAIDs, as well as therapy and surgery as a last resort. We cannot stop this disease as therapists, but we can enhance the person's quality of life by providing them functional things to improve their strength and mobility. And here are my resources, and thank you for letting me speak with you today.